Hello again, and welcome back to the Oncology Brothers podcast. Another exciting annual ASCO is in the books. I'm Rahul Gosain, and along with my brother and co-host, Rohit Gosain, we're bringing you highlights from this conference. There's so much to learn and apply, all from here in our day-to-day practice. To dissect some of the data that we just saw here at ASCO 2024, or as many were calling this as ASCO Lung, we're joined by none other than Dr. Joshua Sabari, a thoracic medical oncologist from NYU. In our talk today with Dr. Sabari, we hope to focus on two plenary discussions and then build up on the theme of precision medicine by touching on anti-EGFR therapy and ALK inhibitors. Josh, thank you so much for joining us.
Thank you, Rahul, for having me, Rohit. Thank you. I'm a huge fan, so looking forward to the discussion.
Thanks so much, Josh. That's very kind of you. Let's get rolling. We have quite a bit to cover. Over the next few minutes, let's dive in with our first study, LAURA trial. Testing for NGS is extremely important every cancer type. However, in non-small cell lung cancer, can't be more critical. With that in mind, talking about Osimertinib, which has been approved in adjuvant setting based off of ADORA trial. Here, what we are focusing on in LAURA trial is use of Osimertinib as a consolidation approach after chemoradiation in unresectable stage 3 non-small cell lung cancer patients with common EGFR mutation. In this trial, Osimertinib was given indefinitely. Your thoughts on this trial and its finding, Josh?
Yeah, I think this is practice changing, but I've been doing this since 2018. You remember the Pacific trial, which looked at all comers receiving Durvalumab in the consolidation setting, post-concurrent chemo-RT. Remember, these are patients with stage 3B, 3C unresectable disease. When we looked at the EGFR mutant patients in the Pacific trial, they did not seem to benefit. And we know that, right? In the metastatic setting, these patients are not the ones who are responding to the PD-1 or PD-L1 inhibitors. So this was the right study to do. The LAURA trial, as you mentioned, randomized patients to receive Osimertinib, the treatment arm, versus placebo, post-concurrent chemo-RT. And boy, was the results phenomenal, right? So a significant improvement in median progression-free survival, talking about 40-month median PFS in the treatment arm versus about 6 months in the control arm. There is a trend towards overall survival. So if you weren't using this yesterday, you're definitely using it today or tomorrow moving forward. And I think the key teaching point here, and I wanted your thoughts about how to get testing done in the early stage setting. You cannot give an EGFR mutant patient stage 3B, 3C disease Durvalumab anymore. We have prospective data showing a significant progression-free survival data and probably a survival data as well.
Josh, thank you for going over that. I have to acknowledge a lot of us were using this already in the practice, but if not, this is indeed practice changing. But when we were using this, it was unclear on the duration. I still am a little hesitant for lifelong treatment. Another anti-EGFR data that was presented, even 6 to 12-month exposure showed some overall survival benefit. I would love to see a trial with more defined duration, acknowledging that in a DORA trial, we saw that once you stopped, there was recurrence. So these are the few things that we have to tackle and keep in mind in our clinic today.
Yeah, Rahul, I couldn't agree more. The 5 years seems daunting to patients. Maybe a biomarker, circulating tumor DNA, something to help us sort of escalate or de-escalate therapy for patients. But we know that stage 3B, 3C disease is essentially metastatic, right? Essentially stage 4. We would never stop an EGFR TKI in a patient with stage 4 disease. So why is this patient population different? I agree with you, though. There is some toxicity with these agents. We do need to understand who are the lower risk 3B and 3C patients. Maybe we can stop at 5 years. Again, those studies need to be done.
And then you brought up ctDNA. I just want to acknowledge right now that is not current standard of care. Until we have better tools, this indefinite therapy is what we have. Okay, so sticking to the same theme of EGFR, we also have some very exciting data with MARIPOSA from Amivantamab and Lazertinib in common EGFR mutations. Amivantamab is currently approved for second line for exon 20. We also have data for this being combined with chemotherapy in first line. Joshua, you've been part of those studies. But coming back to the common EGFR mutations and this recent update on MARIPOSA, can you walk us through these findings and your thoughts on this?
Yeah, so there's really an explosion of therapeutic options for our patients with newly diagnosed EGFR mutations. And here we're talking about the common EGFR mutations, as you mentioned. exon 19 deletion, L858R, also known as exon 21. And in this population, Osimertinib has been a standard of care, third generation EGFR inhibitor. Now, how do we build upon that? We've seen data for Osimertinib and chemotherapy in the FLAURA2 trial, an improvement in progression-free survival, a trend towards overall survival. We're still waiting on that full analysis. Here, this data of Amivantamab and Lazertinib is a potential new opportunity in the frontline setting. This is not yet FDA approved. Amivantamab is an EGFR and c-MET bispecific antibody in combination with Lazertinib. Lazertinib is a third-generation EGFR inhibitor, and this was a very nicely designed study. In the 3 arms, you have the Lazertinib as a contribution of components, you have Osimertinib as a control arm, and the treatment arm here, as you see, Amivantamab and Lazertinib. So we saw this data presented at ESMO, median progression-free survival, 23.7 months, versus the 16.5 months in the control arm of Osimertinib. So positive study and trending towards sort of positivity of the overall survival. What we saw at ASCO, and I think was really exciting, was what about high-risk patient populations? And who are those high-risk patients that we see in our clinic? So we defined high-risk subgroups: patients with brain metastases, patients with liver metastases, high burdens of visceral disease, patients with, TP53 co-alterations. This is upwards of 50% of our patients. And also not approved currently, but some of us are getting circulating tumor DNA to monitor response to therapy. And in those patients who don't clear their ctDNA, this is using liquid biopsy, we also deem those patients to be high risk. And what we saw at ASCO was these subsets. Looking at them, how did these patients do with Amivantamab and Lazertinib versus Osimertinib? And if you looked at any one of these features, one feature alone, it's seen that Amivantamab and Lazertinib favored all of them. Again, to me, this is not necessarily practice changing. This is more of a prognostic biomarker for me in my clinic. I agree. I would treat a high-risk patient once approved with Amivantamab and Lazertinib, but none of these, unfortunately, are predictive biomarkers. And I think we need to distinguish the difference between 2 of those in our clinic. Curious, Rahul, if this was approved, are you using this in your practice tomorrow?
Post-ESMO, ESMO 2023 or ESMO Lung, whatever you want to call that one too, but same thing. We actually did a poll saying you have OC chemo, and then Ami-Laz, where are you going to use it? I was very much in the bucket of saying Osimertinib, then I'm going to use Ami-Laz, and then maybe exposed chemotherapy. You also have HER3-directed drugs there. However, which is what we'll touch on, with Amivantamab having subcutaneous formulation, that also has to change, and we have to keep that in the mix because now it's better tolerated. It's easier to give, less chair time. So with all that, I don't know if that's always going to be my sequence. For high risk, I do think this is going to play a big role.
It's interesting. It definitely is a controversial topic right now. And, do you have this discussion with patients for all 3 regimens in the frontline setting? I agree with you, Rohit. The fact that you have MARIPOSA 2, which is Amivantamab and chemo as an approval in the second line, again, not yet FDA approved, but is NCCN recommended, this is an option for you. So do you hold the option for the second line for Amivantamab? Do you use it in combination with Lazertinib in the frontline setting? I think we need better biomarkers to answer this question. Rahul, you made a great point. If this was equivalent in the sense of toxicity to Osimertinib, I think everybody would use Amivantamab and Lazertinib in the front line because it has better efficacy. The problem is the toxicity. So high rates of infusion-related reaction, right? 65% of patients, high rates of rash, high rates of things like venous thromboembolism, blood clots. So this is problematic. And you're right, the subcutaneous formulation might help deal with a lot of these issues.
Yeah, I think that this is a great segue when we're talking about subcu formulation, Paloma 3, right? Which is comparing subcutaneous Amivantamab formulation. And to be honest, to draw parallels in community oncology, we've seen something very similar happen with Durvalumab, which we use for myeloma day in, day out. We saw very similar infusion reactions. And since subcu, this is all but gone. And that is what we're seeing here as well. Josh, if we were to bring this into our clinical practice, your thoughts on the data here, and because of this, do you anticipate using this a lot more?
Yeah, I think this definitely does play into the discussion here, right? So, for those of you who have not used Amivantamab in the clinic, the current IV formulation you have, an 8-hour infusion, right? And you have to split cycle 1 day 1 into day 2, high risk of an infusion-related reaction, things like flushing, redness, increasing chest pain, shortness of breath. Look at the difference here between subcutaneous formulation of amivantamab and the IV amivantamab, 13% infusion-related reaction for subcutaneous versus 66% for the IV formulation. And this is what we've seen in all of the IV formulation studies. So a dramatic reduction in the infusion-related reaction. And, you guys have more experience with me in general with therapeutics. You mentioned in the myeloma space, also, rituximab, for example, the anti-CD20 antibody. So I think there is a precedence for this. The other thing to me that was really exciting here is we saw a tremendous reduction in the rate of venous thromboembolism. Again, patients were prophylaxed with anticoagulation. The one concern for me is we did not see a significant or dramatic decrease in the rate of skin toxicity. I think both IV and subcutaneous do have a skin tox issue. But what's most important to us in our clinical practice is patient satisfaction and patient outcome. Here's a 5-minute injection versus a 6 to 8 hour infusion. And, I was, involved in the study. And when you ask a patient, what did you prefer, the subcutaneous formulation or the amivantamab? And they say, as much as we like you, as much as we like your staff, we prefer to be home with our friends and family. So I do think this is a game changer. The survival difference here, which was an exploratory endpoint there, I'm not sure. I mean, how do you rationalize that 2-month improvement there in certain progression-free survival? What does that mean to you?
Yeah, this is not the primary endpoint of the study, but this is what we're seeing here. Maybe patients are able to stay longer on this treatment or are more compliant because of just the way it's given. And again, like you've said, better quality of life. This is encouraging, but I am not jumping on the bandwagon of subQ saying, oh my God, the data looks so much better, or there's overall survival benefit. I'm using because this is potential an active agent, and now you can deliver better with better quality of life.
So Rohit, would you need a randomized phase 3 study in the front line of subQ Ami and Lazertinib versus OSI to really convince you? Or are you going to sort of extrapolate from some of these studies that we've been presented and seen over the last few months now?
Well, what we can do is pray and hope these studies are done. And just like with any other thing, that it will be hard to conduct these studies. We'll have to, unfortunately, rely on cross-trial comparison here. Yes, that would be an ideal approach, but doubt that would be conducted. But the important thing is that sometimes a lot of the subcutaneous, the clearance is rather different as well. So that's where we might be seeing the survival advantage. However, we cannot, though this is still 5 minutes, we cannot ignore that Osimertinib is still an oral agent, which is so much more convenient when you talk about to the community oncologists, especially in rural settings where patients do not want to travel in and out.
Yeah, and I agree. I think, for the discussion purposes, I'm still going to use Osimertinib in a tremendous amount of my patients, right? It's easy. It's well tolerated. But a patient with an exon 21 mutation, L858R, we know on the FLORA trial initially, right, that's Osimertinib versus Gefitinib and Lorlatinib, first generation EGFR inhibitors. The EGFR L858R patients had a median progression-free survival of around 14 months compared to exon 19 Del 22 months. So I do think there are still unmet needs, but like you mentioned, Rahul, earlier, we need predictive biomarkers, not these prognostic biomarkers. But again, an exciting time in the field, both for our patients and also for us as we learn about new mechanisms of action, new therapeutics for our patients in the space.
Yes, these are exciting times. And it's, again, Dr. Madashadkian in our conversation continues to mention that these are good problems to have, and I couldn't agree more. So now let's switch gears to another actionable mutation in lung cancer, ALK positive. Here we have Alectinib, Lorlatinib, and Brigatinib available for metastatic non-small cell lung cancer. CROWN study is an update on Lorlatinib, and PFS is commendable. However, this is coming at a cost of higher toxicities. Josh, your go-to ALK inhibitor post-CROWN data and thoughts on the study, please.
Yeah, I think this data was impressive, but I'm still an Alectinib guy in the frontline setting, and I'll talk to you why. I think there are some patients where I will consider transitioning to Lorlatinib. So this is an impressive study, right? 300 patients randomized 1-to-1 to Lorlatinib versus Crizotinib. And, if you do NGS in all your patients, which you should do, you're going to pick up 3 to 4% of these in your non-small cell lung cancer population. This is phenomenal data. You see response rates that are, 80% plus, and look at this progression-free survival here. I don't think I've ever seen a curve like this. I know I haven't been doing oncology for that long, but you could drive 4 or 5 trucks through these curves. The median progression-free survival here for did not reach at 5 years. So 60% of patients are still progression-free. Versus when you look at crizotinib, and a lot of people argue, but crizotinib is irrelevant in 2024, but that was a historical control here. It's 8% are progression-free at 5 years, excuse me. So, hazard ratios here are numbers that I've never seen in my clinical practice. And if you look at the intracranial progression-free survival, Lorlatinib is really, really impressive. Hazard ratio of 0.08. I don't know, Rahul, have you ever seen a number like that in your practice?
Yeah, now this is amazing. Our patients are living longer, and this is a very good problem to have, saying which ALK inhibitor I'm going to pick. This is phenomenal.
Yeah, I think the one issue here is the toxicity, right? And, you have to have a frank conversation with your patients. Alectinib, very well tolerated, does have some constipation, and it can have some skin changes, some liver test abnormalities, especially elevations in bilirubin. But when you look at Lorlatinib, the major toxicities are really the neurocognitive toxicities, the sort of ataxia, gait issues sometimes, and personality changes as well. I think of a patient who's a young lawyer, 34 years old. I really want him to continue to function, to work, to be with his family. So you have to have these discussions with patients. Now, in a patient who has significant burden of brain metastases, or a patient with these tier 3 variants, these are these rare ALK fusion variants that we know patients don't benefit as well from Alectinib and Brigatinib. In that patient population, I may consider utilizing Lorlatinib in the front line. I'm curious if you guys would use Lorlatinib or Alectinib in the front line setting if you saw a patient in clinic tomorrow.
Yeah, I think a few things to mention. One, we need to be better at managing some of the side effects, and not only ALK mutation, but what type of ALK mutation plays a role. But the other thing is, I'm on the same bandwagon here of Alectinib, sequencing some of these ALK inhibitors, right? You can still, in some selected patients, bring Lorlatinib or Brigatinib, and you still have response. So I think that, yes, this PFS is very impressive, but managing those side effects, Alectinib has different side effects that I have to keep in mind. So as of now, Alectinib, having this as an option for the right patient is just critical.
I was going to say most of my patients who do progress, unfortunately, on Alectinib go on to receive Lorlatinib. And we heard the question at the plenary session of, if the PFS is so great, can you stop Lorlatinib after 5 years? And the answer is unequivocally no here, right? We are not curing our patients with stage 4 disease. They're definitely living longer, but we need the therapeutic on board.
And I think any patient would be very hesitant in stage 4 setting to stop this drug, especially if they're tolerating well at the 5-year mark. And again, to that argument, I've been relying on Alectinib, but in past, any of the brain metastatic or high-risk patients, I've utilized Lorlatinib, and patients have tolerated well so far. But again, important toxicity to keep in mind, though.
We all keep talking about living longer, switching gears, because historically that's not been the case when it comes to small cell lung cancer. We've not seen much change here in this space. I know we saw immunotherapy become part of treatment for extensive stage. And yes, we have Lorlatinib and Trastuzumab recently for extensive stage. But again, not much has happened in limited stage. So just before we close, let's dive into another plenary discussion, ADRIATIC Study, where we see Durvalumab being used after concurrent chemoradiation. We've done this in non-small cell lung cancer already with Pacific trial. Dr. Sabari, your thoughts here?
Yeah, I mean, small cell lung cancer is a frustrating disease. We see high response rates up front, but, all patients essentially have recurrence. Here we're talking specifically about limited stage small cell, where there is more, hope. Limited stage small cell is disease that is, localized to one radiation field or port. Even with concurrent chemotherapy and radiation, we know survival is only about 20% at 5 years. So I really love this study design, which took patients with limited stage disease, post-concurrent chemo-RT, and remember, we were using etoposide and platinum here. Patients got Durvalumab versus placebo. We're not talking about the Durva-Tremi arm in this discussion, really focusing on Durva plus placebo. Primary endpoint here of overall survival and PFS. And, we have not ever seen immunotherapy being successful in small cell in a limited stage setting. And I thought this data was extremely practice changing. I will see and think about a small cell lung cancer patient tomorrow with limited stage differently than I did before ASCO. We're seeing 55.9-month median overall survival in the treatment arm versus 33.4% in the control arm. Again, we don't normally see numbers like that in the small cell lung cancer population. When you look at the metastatic, you're really seeing about a 2.5 month benefit for the utilization of these, PD-1 inhibitors like Durvalumab, like Atezolizumab. So clearly a benefit to utilize them earlier on if you can in the limited stage population. So this is something I would definitely do in my practice. You see an improvement in PFS as well as OS. What do you guys think about your practice, utilizing this in your practice? To me, I think it's a game changer.
No, indeed, especially what Rahul and you mentioned, how unlucky we have been with this particular disease, poor prognosis. Yes, this is certainly practice changing starting today itself, actually. Yes.
Yeah, one thing that's controversial here is, radiation and then followed by immunotherapy. There's always the concern, but I think we have a lot of precedent with Pacific regimen, Rahul, as you mentioned, and I think we need more in the small cell lung cancer population. There's a long sort of history of the role for radiation and chemo. I think this really solidifies the utilization of immunotherapy in this patient population. And it's better to cure our patients early because we know once they have recurrent metastatic disease, the cure rate is extremely low in this patient population. Yeah, that idea of starting the immunotherapy quickly after finishing, the chemotherapy and radiation, we've seen that data in the, stage 3B, 3C non-small cell lung cancer population with Durvalumab. I couldn't imagine it would be any different in this population as well. Remember, it's not easy to get patients through concurrent chemo-RT. You do need to support them. You need to work closely with your radiation oncology colleagues. But I think it's imperative that you discuss this regimen with your patients from the get-go, so there's no surprises once they finish their definitive concurrent chemo and radiation.
And again, that goes to say how important multidisciplinary approach is and patient-centered approach. Josh, thank you so much. We've covered quite a bit here and touched on some key practice-changing and informing studies from lung cancer space from ASCO 2024. To our listeners, let's go through a quick summary. Josh, thank you again. With Dr. Joshua Sabari, a thoracic medical oncologist from NYU, we have covered key studies including LAURA, MARIPOSA, PALOMA-3, and CROWN in non-small cell lung cancer from ASCO 2024. There is a common theme here. The importance of testing for NGS in all stages in non-small cell lung cancer is paramount. Then we also had a chance to touch on ADRIATIC Study that is practice-changing from limited stage small cell lung cancer.
For stage 3 unresected non-small cell lung cancer with common EGFR mutation, Osimertinib should now be the new standard of care treatment after concurrent chemoradiation. When it comes to metastatic non-small cell lung cancer with EGFR sensitizing mutations, our options are going to be Osimertinib with chemotherapy, or Amivantamab with Lazertinib based off MARIPOSA data, but the FDA approval is still pending. Amivantamab as subcutaneous formulation, given less infusion-related reactions and cure time for our patients, will make this option come up more and more.
Then, with CROWN study, we see a phenomenal PFS improvement in our ALK-positive non-small cell lung cancer. Being cognizant of side effect and its management from our treatment is very critical. Lastly, we covered another practice-changing study for limited-stage small cell lung cancer as consolidation Durvalumab after concurrent chemoradiation and PCI in the settings improve overall survival. Thank you for tuning in. Make sure to check out our ASCO 2024 highlights for GI, GU, and breast cancer. We are the Oncology Brothers.